He is an excellent speaker, so you can learn a lot from him today. He has offices at AMG Sykes on Martin Luther King Drive and AMG Beverly on Western Avenue. He is an otolaryngologist, board certified, and he speaks Spanish for any of those who speak Spanish. He was educated in medical school at New Jersey, Newark, and New Jersey Medical School in Newark, New Jersey. His residency was done at Rush University Medical Center in Chicago, which he stayed. We were able to keep him here because he met his wife, right?
That's right.
And his fellowship was done at Johns Hopkins Hospital in Baltimore, Maryland. He has many clinical expertise. Do you want me to list them all? Okay.
You could just say my clinical expertise is thyroid cancer.
Okay. Which you will speak on.
Yes.
So thank you.
Okay, thank you so much. Once more, thank you for this opportunity to speak to all of you today. Once more, my name is Max Plitt. I'm one of the Advocate Medical Group head and neck surgeons here. I have specialty training in thyroid cancer, and it's one of the things I'm very passionate about. So today I just kind of want to talk to you, and I felt like this was a really perfect topic to go over thyroid cancer because the American Thyroid Association just released their new guidelines, the 2025 up-to-date guidelines on management of thyroid cancer. And there are some subtle things that are important to spread to patients. So I have no disclosures. What we're going to talk about is like, what is a thyroid? So a lot of times when I see patients who come to see me, they find out that they have a thyroid nodule or God forbid, they have a diagnosis of cancer and they go, what is the thyroid? So we'll kind of talk about that and why we need it. We'll talk about incidence and detection and how we do our workup and really what the treatment options are and how we have some new advances in surgical treatment options and what the prognosis is. Okay, so what is a thyroid? Well, the thyroid is a gland and it's an endocrine gland. And so that it produces hormone that is important in our bodies. It's a butterfly-shaped gland and it sits right over the center part of your neck, over your windpipe. Because it's shaped like a butterfly, it has wings, but we call those lobes, right? So there is a right side and a left side, and then there's a center part, and that's called the isthmus. And it secretes thyroid hormone. You've met people or may have a thyroid condition where you don't produce thyroid hormone anymore. The thyroid hormone that it secretes is T3 and T4, but some of you might know it more as levothyroxine, and that is thyroid hormone. What does thyroid hormone actually do for our bodies? Well, metabolism, temperature regulation, manages our heart rate and blood pressure. And then when we're very young, it's very critical in brain development and growth. So babies who have a deficiency in thyroid hormone develop something called cretinism, or they look like cretins, because they just aren't developing. They don't have that thyroid hormone exposure. And maybe you've met somebody who has thyroid issues and they don't produce thyroid hormone. They always have cold intolerance or they have weight gain because it's responsible for metabolism and temperature regulation in our body. This is what it looks like, right? So it's this pink-shaped gland. It sits right over the windpipe, just below the thyroid cartilage, which is also known as the Adam's apple for men. And we have a right side and a left side. It kind of looks like a butterfly. Okay, so thyroid cancer. So thyroid cancer is actually the most common type of endocrine cancer. If we think about all the types of endocrine glands, we think about the thyroid, we think about the pancreas, it's the most common. And incidence of thyroid cancer has risen, but it's really because we've been improving detection, not necessarily because the disease itself is increasing, because most cancers are found by accident. Most of the time, a thyroid cancer, which usually presents as an irregular thyroid nodule, is found because you got a CAT scan or an MRI for some other reason. And that's what happens. Because most of these things are small and you might not even notice it was there to begin with. The good thing is that most cases are found early and are highly treatable with appropriate treatment. So we look at long-term data, the 10-year survival. That means after 10 years of diagnosis and treatment, greater than 95% of people are still alive. That's pretty good for for diagnosis of cancer. And this is specifically for what we call well differentiated, or like the low grade cancers such as papillary and follicular, which are the most common. Survival may be a little different when it comes to other types of cancers like medullary anaplastic. These tend to be more aggressive. We won't really talk about those as much. Papillary, yes, yes.
What is the meaning of the word endocrine?
Endocrine, it just means that it's something that produces something, and it specifically produces a hormone. That's what endocrine means.
And
It's
what
in
are,
the body and it produces hormone.
and you mentioned what the pancreas is another endocrine?
Yeah.
Are those are the two, or is there many more?
No, there's other ones. There's like the pituitary is another example of an endocrine gland. The adrenal glands are another example of that. Okay. So papillary thyroid cancer is the most common of the thyroid. If you met somebody with thyroid cancer or been treated for it, they probably had papillary. It's 80% of all cancers, and there's approximately 44,000 cases of thyroid cancer per year. There's other subtypes, and those are follicular, which is the next most common, approximately 10% of cancers, and then those two other ones that are a little bit more aggressive, medullary and anaplastic, are much more rare. Okay. So thyroid cancer is detected usually by an irregular appearing thyroid nodule. So we're going to use some terminology. So there's thyroid cancer, which is a diagnosis. A thyroid nodule is just a growth of thyroid tissue. That's all it is. And it's usually that use that terminology based on an ultrasound report or a CAT scan. A nodule, it's a growth of tissue. And it's growth of thyroid tissue, which is called follicles, right? So your thyroid produces this hormone, it has these little tiny follicles within the gland that are microscopic. Sometimes those can just grow and fill with fluid and tissue and all these kind of things for a whole host of reasons. Some of those being thyroiditis, which is the most common form of problem with the thyroid, and that's why most patients are on thyroid medication. Hyperthyroidism or overactive thyroid, genetic conditions, or family history. You may have heard the term goiter for some people who have very large, big thyroids. That's just a genetic condition that can cause thyroid nodules to grow. Thyroid nodules are common, okay? And 50% of adults over the age of 60 will have a thyroid nodule. There's a good chance that one of us have a thyroid nodule and we don't even know about it. What's the good news is that 5 to 10% of these nodules are cancerous. We don't lose sleep over thyroid nodules. What we care about, though, is the size of these nodules and the characteristics, and that's what changes if it's going to increase or decrease the risk of cancer. Other than these found by accident, the most common presentation of thyroid cancer is a mass in the center part of your neck. You feel a lump right by your windpipe. Other symptoms, you might feel a lump somewhere else in your neck, and that could be indicative of a lymph node that has cancer that's spread to. Hoarseness is another one that's important. We'll touch on that reason why, but hoarseness can be a presentation of thyroid cancer, changes in your swallow, or sometimes really shortness of breath. But like I said before, majority of the time, these things are found by accident initially on a CT or an MRI. They weren't even looking for this, and it just happened to pop up. And then based on a recommendation, they'll say, let's get an ultrasound of your thyroid to take a more detailed look at it. Very rarely, if you got a PET scan for another type of cancer or another process, nodule might light up on PET scan. And that requires a workup. So here's an example of a young lady with a thyroid nodule. Okay, we don't know what it is, but that's a common presentation. Okay, here's some images that this is like what we're looking at when a patient comes in with a nodule. So here, this is a CAT scan. This is the front part of the neck. Here's the windpipe. This is the normal thyroid. This is the spine. And then you see this thing. We call this the arrow sign. In medicine, someone pointing arrows at the thing that we're looking at. That's a big thyroid nodule. And then if you look on the other side, this is an ultrasound, right? So right here, you see this dark circle. This is the right thyroid, this is the windpipe, this is the carotid artery, and right here, right next to that windpipe, you see a dark circle. That measures about a centimeter. I would bet money on that that's a thyroid cancer. In fact, I know it's a thyroid. So risk factors, what are some risk factors? So thyroid cancer is a little different. It's not like your typical head and neck cancer or colon cancer or lung cancer, not associated with smoking. Risk factors are females tend to get more thyroid cancer than men. That's interesting. And the reason why is because females tend to get more thyroiditis. So thyroiditis is inflammation. It's your body is attacking and activating the thyroid, and that can change the chemistry of the thyroid, and then that you can develop thyroid cancer. So the thought is, because of that, it's why females are more likely to be diagnosed with thyroid cancer. Family history is probably the biggest risk factor, right? So if you have a strong family history of thyroid cancer, it increases your likelihood of having thyroid cancer. Age is important, so greater than 45, that increases your likelihood of having thyroid cancer. I think the next point is very important, and it's one of the questions I always ask in the office is that radiation exposure, especially in childhood. And we get CAT scans and X-rays for a lot of reasons. We go outside, we're exposed to radiation, but we're talking about serious amount of radiation, like if you grew up next to Chernobyl. And there actually is well-documented history of childhood thyroid cancers from people living in the periphery of Chernobyl. This is a real thing, and that's because of the intense radiation exposure increased their risk factor for thyroid cancer. In fact, I've met some people and have treated them who've been exposed to Chernobyl radiation and ended up developing thyroid cancer. And below that, we see EBRT, what we call radiation therapy for treatment of other cancers or conditions. So like lymphoma or head and neck cancer, that will increase your likelihood of developing cancer. Then there's genetic syndrome. So Cowden syndrome, MEN, PTN. I'm not expecting you guys to know that. It just means that you might have a predisposition to developing thyroid cancer. Okay, so diagnosis always starts with a history and physical. Most of the time when a patient sees me in the office, I already have all the information. I already have a kind of a plan of attack, but I'm still gonna ask questions. So do you have a family history of thyroid cancer? Any history of thyroiditis or inflammation? Do you take thyroid hormone for any reason? Have you ever been exposed to radiation? Do you have any imaging that I can just take a peek at and see what's going on? So my physical exam, I'm going to examine your neck, of course. But I will tell you 90% of the time, I'm not going to feel anything. Why? Because most cancers, less than 2 centimeters, are not palpable by physical exam. You just won't be able to feel it. And remember, that goes back to that original concept that most of the time these nodules are found by accident. You didn't even know it was there. Okay. And so is there hoarseness of the voice? Is there any wheezing or changes in your breathing or more audible breathing? Okay. The next most important thing is to get an ultrasound. This is the workhorse diagnostic tool. Now, ultrasound is not a CAT scan and it's not an MRI. Ultrasound is a type of probe that doesn't have any radiation and basically is able to look at areas in the soft tissue with very fine detail. Okay, so this is an example of a normal thyroid. This is what we're looking at. We're looking at the butterfly-shaped gland right here. And this is what the transducer looks like, and this is something I do in the office for all my patients. All right, it's extremely accurate to assess the thyroid.
So that's the mass of the middle,
Nope, that's the windpipe.
the windpipe, oh.
Yeah, so this is the windpipe. This is the isthmus. This is the right side and the left side. So the right wing and the left wing of the butterfly. Okay,
And that's the windpipe.
and that's the windpipe right there. Okay. All right. So when we look at a nodule and we look at an ultrasound, what we care about is size and characteristics. Remember, not every thyroid nodule is cancer. In fact, it's only 5 to 10%. So we're not going to go and biopsy or work up every single nodule. We came up with guidelines in order to help clinicians determine what are the nodules that we worry about and what are the nodules that we don't worry about, okay? And so there's actually 2 classifications. I tend to use the ATA guidelines, I'm biased, but there's also something called Thyroid classification. Just remember, not every nodule is cancerous, okay? This is a busy slide, but this is basically how to work up every single nodule. This is from the American Thyroid Association, okay? You start with a thyroid ultrasound, or there's a suspected thyroid nodule, and based on the pattern of how it looks, we'll determine, is it biopsy required? And if so, at what size cutoff will you recommend a biopsy? Okay? And then from that, the biopsy is performed, and then you get some of these results, okay? So that's what I do in my head every time I see a patient with a new thyroid nodule. I'm doing that in my head. And what are we looking at? This is what we're looking at, okay? So right here, you see how it's basically just all black? That's because it's filled with fluid. And a cyst, the likelihood of cancer is like near zero. Right? And so that's a thyroid nodule, right? That can present as a mass, but that's bad. And then very low suspicion will be like, well, it's mostly filled with fluid, but it kind of looks like a sponge. That's also very low risk for cancer, okay? So then when we start getting higher and higher up, what we're looking for is the mass solid? The more solid a mass is, the more likely it's going to be, okay? But then not only are we looking at is it solid, but is it dark? Dark and solid. Okay, so that's what we care about, dark and solid. And then lastly, are there any suspicious features that were like, this looks bad? And that's where you get, it's dark, it's solid, and it's got these little calcifications in it, or it's dark and solid, and it looks irregular. You see how this border is nice and smooth? You're like, yeah, that looks nice and smooth. I can see, it looks like a perfect circle almost. Same here, perfect circle. But as soon as that circle starts getting irregular, then he's thinking, okay, that could be like a cancer, right? Cancer growing out of control.
For the various ones you have in this
Yeah.
slide, roughly, what is the age or how long have they been? I mean, are they
How long have they been
5 years old or 5 months or
That's
what?
a great question. The answer is, I don't know. What we know about thyroid cancer is that patients do really well and they are slow growing. Could have had it there for a year, could have had it for 5 years.
So typically very low, very.
Usually it's there for a pretty decent amount. A thyroid cancer will probably grow a little bit over time, like every year.
And just if you would meet a person.
Yeah.
The only kind of hint is a very slight bulge, almost in the center of the,
Correct.
to one side.
Or to one side, yeah. Or a very large bulb.
Is there any discoloration or redness or?
Not usually, unless it's a very aggressive, very nasty cancer, then you might have color changes. And that's when we start talking about those more aggressive ones like cancer.
And it is what, like a goiter, is it kind of different on the neck?
A goiter is an enlarged thyroid, which is not cancerous.
Oh, okay. But a goiter is, the whole neck is kind of swollen,
Correct.
whereas what you're looking for is kind of localized.
Correct. Yes. All right. So sometimes patients get confused because they'll say, well, I had my ultrasound report and the ultrasound report is saying I don't need a biopsy, but maybe someone else is telling me I do need a biopsy. What's this TIRADS classification? What's ATA? How come you're telling me I need a biopsy? Why is it confusing? Well, because it's confusing. And so I love this slide. This slide, I think I got last year at the American Thyroid Association. As you can see, what we did was we basically lined up all these classifications that you'll see on an ultrasound and combined them with what the American Thyroid Association say. And for the most part, these first two are the same, and these last two, this last one is the same. Where it gets a little tricky is the American College of Radiology will say for mildly suspicious nodules, biopsy greater than 2.5. American Thyroid Association will say greater than 1.5. And then when you get to a moderately suspicious, they'll say 1.5 and intermediate suspicion 1. That's not really important for you guys, but it's more about understanding that there is a little bit of discrepancy. And what we're trying to do as an organization is we're trying to pull all this data and just make it be centralized so it's easier for patients to digest. The new data is gonna come out hopefully soon, that's gonna combine these and just say it's a range. And it puts the patient at the center of the decision making.
Can I ask a question?
Yes.
That's fine.
Yep.
Why is it that the lower suspicion
Mm-hmm.
has a larger
Mhm.
size?
Mhm.
And to go to a greater suspicion with the intermediate suspicion,
Mm-hmm.
it is a smaller size.
Yeah.
And I would think the more serious it is,
Mhm.
it's constantly growing larger and larger, no?
That's a great question. So what it's basically saying is, let's say you see something that's very small, but looks very, very likely for cancer. Then your threshold for biopsying that nodule should be a lot lower. If you see something that's bigger, but it still kind of looks benign, your threshold to biopsy it is a lot higher. Does that make sense? Sort of? Okay. Basically, it's what this is translating to is the smaller and more suspicious something looks, the more likely you want to diagnose it quicker when it's the smallest.
Okay,
Make sense? The larger a thyroid cancer is, the more likely it can spread. And if you catch it very small, very early, then that's less likely it's gonna spread. That's what it translates to. All right. So ultrasound detects nodule size, the shape, how it looks at the lymph nodes of the neck to see if any are enlarged. It also helps us do biopsies. All right, so Yeah.
The biopsy. You say
I'm gonna get to that right now.
Okay.
Perfect timing. So for diagnosis, okay, there's an irregular thyroid nodule and it meets criteria that will require a biopsy because we're concerned about a cancer. Then we do something called a fine needle aspiration biopsy. I take a very small needle in the clinic, I numb up your skin, and I insert that small needle directly into the nodule, and I use an ultrasound to guide my path. It takes 5 minutes. I do it in the office all the time. It is not invasive. The biggest risk is a little bit of discomfort and maybe a little bit of bruising, but that is it. This is what it looks like. Okay? So this is what I do for patients in the office. I'll numb up this, so this is a nodule that we want to biopsy that looks irregular. I numb up the skin around it, and I put a very fine needle, use this ultrasound to guide the needle into the perfect position, and then I put it on these slides. Okay? This, yes,
Would a nodule always present facing outwards?
not always.
Could it be, okay,
Sometimes it can go down, sometimes it can go more backwards.
is that a different type of biopsy or? do you
Nope,
just-
same biopsy. Just go, you gotta go a little deeper or a little bit more down. All right, this is another busy slide. Basically what this means is I do a biopsy of a thyroid nodule. And now I look under the slides, it could be one of these 6 categories. One of these 6 categories will determine our next steps. Okay? So non-diagnostic means we gotta repeat it, we didn't get enough tissue. Benign means there's nothing to do. And then if we go all the way down, malignant means, yes, it is cancer, the likelihood of cancer is 100%. We'd recommend next step would be surgery. Then you fall somewhere in between here. And that's where we're getting into the weeds. Back in the day, I would say like 1990s, maybe even early 2000s. If you had one of these like atypical diagnosis right here from this biopsy, someone might say you should get your thyroid removed. And then when the final pathology comes back, it says you don't have cancer. So we were realizing we were doing a lot more thyroid surgery than maybe was necessary. And so with time and data, kind of thinking critically, we determined that, well, if we get one of these categories, what is the actual risk? And the risk is about 5 to 15%. This is a little inaccurate. 5 to 15% and 15 to 30% risk of cancer. Well, is there any way we can shift that? And the answer is yes. So we do genetic testing now. So if you get one of these weird diagnostic categories, we can actually test the genetics of it. And what does that do? Again, it puts the patient at the center of decision making and says, okay, You're telling me my risk now with this genetic testing is 0? Well, I don't want surgery, I don't have cancer. Well, if you're telling me now with this genetic testing that my risk of cancer is 97%, I should probably get surgery. It just helps give patients more information to help make an informed decision. Instead of getting the surgery they probably didn't. All right, so then we talk about management. You can see the title says surgical management, and the reason is because surgery is the mainstay of treatment for thyroid cancer. This chemotherapy doesn't work, radiation doesn't work, or targeted radiation doesn't work. Surgery is the mainstay of treatment of thyroid cancer 99.99% of the time. Now, the amount, the extent and the type of surgery depends on the type of cancer you have, the size of the cancer, and if it's gone anywhere else in your body, okay? And so these are really like the 3 things that would be offered to you if you got diagnosed with thyroid cancer. So the first is thyroid lobectomy, which means half of your thyroid removed. Total thyroidectomy, which means all of your thyroid removed. Or do we need to combine some of these and dissect the lymph nodes? Those lymph nodes that may have cancer in them. Okay. Well, here's an example, right? So here's, remember, the butterfly, you have a right side and a left side. A lobectomy means half of your thyroid is going to be removed. Means the other half is still there. Okay. Total thyroidectomy, the whole thyroid is removed. You have no more thyroid. In regards to like risks of surgery, this is a side view of the thyroid. Okay, you have your windpipe over here. Here's the gland. You have these pink dots here. Then we have this yellow line. I love this image. I use this image when I'm teaching residents. This yellow line is a nerve, and that nerve controls movement of a vocal cord. That's called the recurrent laryngeal nerve. That is why thyroid cancer, if it's aggressive, can present with hoarseness, because it hurt that nerve. Okay, but surgery, in order to remove the whole thyroid, you got to find that nerve and protect it, so surgery can hurt. Okay, so there's a risk of hoarseness with surgery. When you also take out the thyroid, you have these little pink glands right here. Probably never heard of these. These are called parathyroid glands. We have 4 of them in our body. We have 2 on each side. Each thyroid half has 2 glands. What do the parathyroids do? They control the calcium level in your blood. That's it. Probably never heard of it. Why do you care? You want to protect those glands. They serve a function. If you remove all of the thyroid and you remove all those parathyroid glands by accident, you will be permanently low calcium for the rest of your life. Okay? So there's a, yeah.
And the nerve that you said is so critical, what, if that is damaged or
You'll have hoarseness.
what, you cannot speak in or what?
You'll be able to speak, it'll just sound different. It might. Like a whisper.
And then, there you
Now, the risk of that, we say there's a temporary risk of hoarseness and then rarely permanent, right? So even if you hurt the nerve, there's a good chance it's gonna come back. Might take some time. And so when I counsel my patients, I say there's a 1 to 2% risk of temporary hoarseness. And very rarely 1 out of 1,000 risk of permanent hoarseness. Okay. All right. So that's the anatomy. Now, what are the risks? Bleeding, infections, fibroma, need for thyroid hormone medication, right? We're removing part or all of your thyroid. Well, what's going to produce the thyroid? Nothing. You need to take the supplement. And so that would be like Synthroid or levothyroxine. And just taking that for the rest of your life, it'll be like taking a vitamin. We talked about the temporary permanent low calcium, the hoarseness, need for further surgery. We'll talk about that in a second. Okay. So this is where I start getting into the minutia, but these are real conversations that I have with patients in the office every day. So taking out half of your thyroid, why is that an advantage? Well, it reduces the likelihood that you'll need thyroid hormone. Well, that kind of makes sense, right? So it's like you have a thyroid, it's functioning properly, I'm going to remove half of it. That means I'm getting rid of half of the function. But the good thing is, actually, it's a little bit less than that. If you remove half of the thyroid, about 30 to 40% of patients will actually need medication. Right? So the more thyroid tissue that you spare, the more likely they will not need replacement. Okay? If you take out only half of the thyroid, you don't have to worry about calcium. Because you have two parathyroid glands on the other side. You only have to worry about one nerve. But there is something that is real that I talk to patients about, which is the need for second surgery. Now, why would you need second surgery? Well, for a couple reasons. You remove a thyroid cancer from one side of your thyroid, there's a chance something can pop up on the other side. Or we take out half of your thyroid, and when we get the final results, there are some findings on those results that tell us there's a higher likelihood that you're going to have recurrence of your cancer. So you may need to take the other side out, and you may need further treatment. So that's a gamble that patients play, and that's why you guys are at the center of decision making, right? Because we know that there's no perfect answer. There's no perfect surgery. There are just risks and benefits, and you gotta weigh those out.
If you average it out, Phil, from
Yeah.
all of your content with your clients,
Yeah,
typically, roughly, what is the percentage? 70% are go for partial
it depends.
removal and only 30%
It depends.
cannot, okay.
Yeah, I can't generalize. I would say, well, I will say overall, we are starting to shift more to taking just half.
You're taking what?
Taking just half of your thyroid. Because we're seeing that even if you take all the thyroid, patients still just do as well as you take out half. And so we're starting to shift away from more aggressive surgery, okay? So total thyroidectomy, what are the risks? Well, if we remove your whole thyroid, you're not gonna have a thyroid anymore. You will absolutely need thyroid hormone, right? Makes sense. Risk of low calcium, that's real. Now you're putting all four of those parathyroid glands at risk. And so there's a temporary 1 to 10% chance of low calcium, which will recover. Means that you may need take some Tums or take some vitamin D while you're recovering, and it will get better. Very rarely, 0.1%, will you have permanent low calcium. Okay. If you do double surgery, you put two nerves at risk. You do not need a second stage surgery. And you'll allow you to trend something called thyroid globulin, and then maybe peace of mind. We'll talk about that. So thyroid globulin is also produced by thyroid. If you have thyroid cancer, thyroid globulin is a blood test that we will use moving forward to see if your cancer has come back. Here's a catch though, that only works really well if you have no thyroid left. If you take out half of your thyroid, you can't trend thyroid globulin. That means that you have to get ultrasound instead. You take out all of your thyroid, you don't have to worry about it. They'll just test your blood. You know, every 3 to 6 months. Peace of mind. Some people like the idea of, hey, I don't want to think about this ever again. I don't want to have to worry about that other side. Just take it all out. That's reasonable. And again, the emphasis now is that patients are at the center of decision making. Right? This is not patriarchal medicine. I'm not saying you need surgery, this is whatever we do. You are at the center of decision making. So the preferred treatment has evolved, and that's alluding to your question. So before it used to be, if you have thyroid cancer, it doesn't even matter if it's a few millimeters, total thyroidectomy, and you're gonna get something called radioactive iodine, period, end of story. What is radioactive iodine? It's basically a pill that you take. The thyroid produces thyroid hormone that has iodine in it. That iodine will go and destroy microscopic cancer. Okay, can only be used after a total thyroidectomy. But what we learned, now that it's 2025, what we've learned is that small cancers less than 4 centimeters with no high risk features, taking out half or taking out all of your thyroid does not make a difference long term. Okay, so now thyroid lobectomy or half of your thyroid removed is preferred. Okay. This is good. This means less surgery. All right, so the new guidelines came out. The American Thyroid Association guidelines came out for well-differentiated thyroid cancer. And basically, it summarized treatment for 90% of all thyroid cancers. And so what they said was for unilateral, meaning one side, common thyroid cancers, less than 2 centimeters, you only need to do a thyroid lobectomy. Okay. Now, not every patient reads the textbook, as we said. Well, what if you have a nodule on the other side that looks suspicious? What do you do then? This is why patients are at the center of decision making. So you can say, hey, I don't like how that thyroid nodule looks. Your biopsy is fine, but we could just take out the other side as well at the same time, even though that increases some risk of other things. So as you can see, it can get a little complicated. But the American Thyroid Association is saying, you're kind of in charge. We'll just tell you what our recommendations are, okay? But what we know is if it's less than 2 centimeters and there's nothing on the other side, you only need a lobectomy period. Okay? If it's between 2 to 4, half is still preferred, but removing all of it is still an option. And again, the patient is at the center of this decision. So why would you have a total thyroid? Well, shared decision making. If there's concern for multiple thyroid cancers, which can happen, we call that multifocal. Sometimes when you have one thyroid cancer, it can spread to the other side within the thyroid. You have nodules on the other side. If you have a condition called hyperthyroidism or Graves, where your thyroid produces too much hormone, well, maybe taking out the whole thing will allow us to get your thyroid under control. If there are lymph nodes involved with cancer, if you have cancer that has spread to lymph nodes in your neck and you need to have those lymph nodes removed, you 100% need your whole thyroid. Why? Because we will not be able to track your cancer unless the whole thyroid. Okay.
Can you distinguish the percent or the occurrence of thyroid cancer? How frequently is the result of the growth from an adjacent lymph node as opposed to an actual nodule within the thyroid causing the cancer?
I think what you're asking is how often.
From an associated part of the body, which already had, with the spreading of the cancer.
Yeah.
How frequently is the occurrence of cancer in the thyroid a result of that expansion from a different source, where, like you said, in the back of the neck or the arms or whatever?
Well, it always originates from the thyroid. Is that what you're asking?
I'm sure, as I understand it, they talk about if you have cancer at one location, you are always concerned about what stage is it in.
Correct.
And the higher the stage, the more is the likelihood that it has spread to other parts of the body.
That's correct.
So I am curious to know specifically for thyroid cancer, roughly the percentage is occurring because of growth from a different part of the body that now is affecting the thyroid, as opposed to the thyroid itself being the source, the original source of that cancer.
The thyroid is always going to be the original source of that cancer.
So it never will be a result of expansion of a different cancer from a different part of the body.
I mean, anything that could be, anything is possible. You can have 2 cancers. Usually that doesn't happen. So what I think what you're asking is it a lymph node in your neck? If that's enlarged, how will you know if that is thyroid cancer?
If that is the source really of the thyroid cancer.
Yeah,
that
you biopsy it. You perform a biopsy then.
Oh, and
So you can biopsy the lymph node as well, and if it has thyroid cancer in it, then you answer your question. Make sense?
Okay.
Any other questions? All right, so in summary, taking out half of the thyroid is now the preferred option for one-sided thyroid cancer is less than 4 centimeters. Total thyroidectomy is still an option. Radioactive iodine, which is that pill that you take, we're a lot more selective at who needs it, but that's still an option. In bold, I have here emphasis on patient-centered care. I keep emphasizing that because it's shared decision making, right? There's no right answers. There's definitely some recommendations, but you are at the center of the decision making and give you all your options. There's no one size fits all. Yep. All right, so what are some other advances that we've done? So like, okay, traditionally you make an incision on the neck to remove the thyroid, but there is something called transoral thyroid, or we call it scarless. Basically is, instead of making a cut over here, you make a cut on your lower lip and endoscopically remove a thyroid cancer. And that's something that I have training in and I do. Similar risks, it's slightly longer and you avoid the neck scar that people worry about, and it's ideal for smaller cancers, and so this is kind of what it looks like, which seems a little crazy and barbaric, but it's a way of not having to make a cut on the neck. So we do that endoscopically. Non-surgical, yes,
We have a preference.
whatever the patient prefers. I prefer open surgery. It's a lot easier. Just because everything is open, you can manipulate things. Transoral surgery, you're working in a small tunnel. But it's whatever the patient prefers. Okay. So then, non-surgical options. But wait, there's a diagnosis of cancer. What do you mean non-surgery? Well, you can recommend active surveillance for small papillary thyroid cancer. And that goes back to your original question. Well, how long has this thing been here? Maybe for a while. Because we know that some thyroid cancers don't really grow. They kind of there and they just stop growing. And so let's say we're trying to make shared decision making. And let's say looking through your chart and you have a lot of comorbidities. You recently had a heart attack and your blood pressure is out of control, bad diabetes, and maybe you're not the best surgical candidate, you just got diagnosed with a small thyroid cancer. Well, there's really good studies that show you can watch that cancer. And you get an ultrasound every 3 months. Because sometimes it doesn't grow. And so there's some really good data that shows that even cancers less than 1.5 centimeters, you can just watch them. There's also radiofrequency ablation. So radiofrequency ablation is you take that same small thyroid cancer that's just isolated into the thyroid, and instead of cutting it out, you shrink it and destroy it. That's called ablation.
So you said you have 2 glands. Right? 2 glands. That development. You have 2 glands.
It's one gland, but it has 2 lobes.
2 lobes.
Yep.
Because of that, is that good like digestion, like you said, the growing calcium, what you're intaking?
It does not have to do with digestion. It does, though, the thyroid does sit next to the esophagus, which is responsible for food passing from your mouth to your stomach, but it doesn't play a role in digestion.
Okay.
All right. So radiofrequency ablation is a non-surgical option. This can be done in the office under local as well. So we numb up the skin, just like we're doing a biopsy. And instead of putting a small needle, you put a needle that has a microwave at the end, and you can actually heat it up from the inside and destroy the cancer. It's also an option for small cancers that are within the thyroid. Okay. Why is this ideal? Well, we're maintaining as much thyroid tissue as possible. Remember, there's that risk, even if you take out half of your thyroid, you still might need thyroid medication. Well, what if we could just destroy only the thyroid cancer? Then the likelihood of you needing thyroid medication is near 0. So it's another option. Okay. This is an example of it. So use an ultrasound device, here's the cancer, and here's the hot probe, and it melts it. Now, you gotta make sure that that cancer is not spread anywhere else. Still need to do surveillance to make sure that it hasn't grown or changed after you destroy it. But that is an option. Okay. So for adjunct, so after you get diagnosed and you have surgery and treatment, you may need thyroid hormone replacement to suppress your thyroid and reduce the recurrence risk. You may need radioactive iodine. Thyroid globulin testing, so we're gonna just test your blood every 3 to 6 months to a year. And that acts as your cancer marker. If that thyroid globulin test stays steady, you're good. And they now say at 5 to 10 years, you might even be able to stop checking. Okay. But if that's slowly going up, then you start thinking, has this cancer come back? Okay. So prognosis, so like we said before, excellent overall survival, greater than 98% 10-year survival for low risk patients. Recurrence rates are low with proper treatment and follow-up, and minimally invasive and non-surgical approaches maintain good quality of life. And multidisciplinary care ensures optimal outcomes, right? So it's a combination with the surgeon, your endocrinologist. We have a tumor board every Thursday, so tomorrow, where we present patients with cancer, we talk about options and management. So it takes a team. So what are the takeaways? Most thyroid cancers are curable and they are slow growing, and survival rates are pretty excellent with the appropriate treatment. Treatment is highly individualized to the patient, with you being at the center of the decision making, and there are minimally invasive and non-surgical options which are expanding. Okay. This is me. And this is our awesome team. That's it.
Question,
Yes.
what is the comparison of the frequency of thyroid cancer compared to the other cancers, lung cancer, pancreatic cancer?
Yeah,
Break it down.
I think it's the third, I want to say it's third or the fourth most common. Breast is number one, but breast, I want to say it's breast, lung, colon, and then thyroid probably somewhere else. Yeah, breast, lung, colon. Yep.
Does a nodular cancer affect the functionality of the thyroid in any way, or is that not really acceptable?
Not really. Sometimes if you have a lot of nodules, it could mean that underneath your thyroid is overactive, or it could be under. But just having a nodule does not mean that it's gonna change the function. But if you think about it the other way around, it could be that having multiple nodules could mean that it's overactive or. Yeah. Any other questions? All right.
Thank you very much.
Well, thank you guys for your time. All right. Excellent. It was really nice seeing you guys. Thank you.
Have a good trip.